So let's talk about rheumatological markers. Now I'm not so sure rheumatological is an actual word, but Google says it is, so I'm going to use it. And the first thing to know about these markers is to never make a diagnosis based solely on these lab results. It's estimated that 25% of people currently have positive markers and will never develop an active disease, while other patients have active disease without a single marker being present. So these markers are only used in concert with the clinical manifestations of a disease to make a diagnosis. So with that said, let's start talking about the 9 most common rheumatological diseases and their associated laboratory tests. First is rheumatoid arthritis. This is what everyone likes to think of when they hear the word rheumatology, but in actuality, the most markers are found in lupus. And lupus has 2 associated diseases, antiphospholipid syndrome and drug-induced lupus. So a lot of markers can be there. We also want to talk about Sjogren syndrome, as well as Crest syndrome and scleroderma. And of course, we cannot forget myositis and vasculitis. So the first marker that everyone loves to get when they think a patient has a rheumatological disease is an ANA. Now, an ANA test is not just a single marker, but is a series of markers that point to different disease processes. You notice there's a titer number underneath the letters A and A. It says 1 to 160. A lot of ANA tests will indicate a positive result at 1 to 40 and 1 to 80, but rheumatologists find that 1 to 160 is when the test becomes clinically relevant. So let's say there's a patient you think has lupus and the ANA is over 1 to 160. Now you need to break down the ANA into subtypes, and the first marker you're looking for is an anti-double-stranded DNA. Never order an anti-single-stranded DNA. This is worthless to a rheumatologist. A positive anti-double-stranded DNA points strongly at lupus. You might also see an anti-Smith as well as an RMP. Now, an RMP becomes important when you think a patient has mixed connective tissue disease, but we'll get to that in a bit. So now you have a large set of markers for lupus. But what if the patient recently started a medication that might induce lupus? Well, you can order another ANA subtype called an antihistone. Now, an antihistone is a funny test in that it can point in both directions. It can indicate lupus by itself, but is 95% accurate in predicting drug-induced lupus. So really, the presence of a new medication is key. And there'll be a list of these medications at the bottom of the chart when we're finished. Okay, let's get away from an ANA test for a second. Let's say you have a pregnant lady with lupus and she's had some miscarriages in the past. You'll need to order a series of tests looking for antiphospholipid syndrome. These tests are lupus anticoagulants, anticardiolipins, and B2GP1. Switching gears, let's look at rheumatoid arthritis. Now, another favorite marker is rheumatoid factor, and a lot of people think that this points directly at rheumatoid arthritis, but not necessarily. Rheumatoid factor is also seen in Sjogren syndrome as well as lupus. This is a very nonspecific test that uses IgG markers. So if you think a patient has rheumatoid arthritis, then you need to order a more specific test called a CCP antibody. This test, combined with clinical presentation, really points at rheumatoid arthritis. Now let's look at Sjogren's. Once again, you need to go back to some of the subtypes of the ANA test. This time you want to look for SSA and SSB, with SSA being more specific for Sjogren's than SSB. Together, these markers are called Sjogren's antibodies. However, it's important to note that these 2 markers can also be seen in lupus. This is why it's important to compare your results with your clinical correlation. Now switching to the other side of the chart, we have Crest syndrome. When investigating this disease, we're once again looking at an ANA subtype, this time called an anti-centomere. This is the best marker for Crest. And if you believe a patient has scleroderma, then you need to order another ANA subtype called an SLC70. Now that finishes the main chart, but let's not forget about vasculitis and myositis. When you suspect a patient has vasculitis, you need to order 2 tests, one called a C-ANCA PR3 and the other called a P-ANCA MPO. A C-ANCA test points towards the dreaded Wagner's granulomatous, and the P-ANCA points more towards microscopic vasculitis. Okay, the last condition with markers on our list is myositis. And of course, we're going back to our ANA subtypes for this diagnosis. This time, you want to order a test called a JO1. This test, along with muscle biopsies, really nail down the diagnosis of myositis. I'll put some notes on myositis at the bottom of the chart along with a list of drugs that induce lupus. It's important to remember there are no absolutes in rheumatology. Patients can have combinations of markers and odd clinical presentations that don't seem to make sense. There's even such a thing as mixed connective tissue disease, and that means that patients have two or more of these conditions at the same time. The RMP marker found in the lupus chain is usually positive for a patient that has mixed connective tissue disease. So, to avoid a lot of work for everyone, order the test most consistent with the clinical presentation of the patient and then refer them to a rheumatologist.